Parkies in a Pod is powered by Parkinson's UK, the charity that's here to support every Parkinson's journey every step of the way. Wherever you're from, whatever you need, visit parkinsons.org.uk for more information.
It's getting hot in here, so take off all your clothes. Hi there. Very welcome to Two Parkies.
It's not that kind of podcast. We are fully clothed. I'll have you know.
Podcast for people with Parkinson's, by people with Parkinson's. I'm Dave. He's Kuhn. We're sweaty.
We're sweaty, yeah. It's a little bit hot. It's heat wave after heat wave. I had enough of it.
Really hot, isn't it? We've got another one coming.
I know. I'm done with it. Bring on autumn. We've spoken about it before, right? We don't tend to fare well in these conditions, do we, us Parkies? I'm overheating.
Meds don't work properly. My Neuropro, my patch doesn't stick properly. It's a nightmare.
The adhesive, you mean?
Yeah, I've been going to the Lido though. That's been nice. Swimming's been good.
Very
lovely,
good.
cool water. Tooting that Lido, which is gorgeous. 100 yards long it is. Massive.
It's quite daunting to look at. I haven't been in it, but it's a proper Olympic-sized pool, right?
Bigger than Olympics. It's nearly twice the size of the Olympic pool.
Right.
It's huge. Absolutely huge.
And I hear you've been going to the cinema.
I went to see The Odyssey, yeah.
How was it?
The big movie of the time. It was really good. 3 hours long. I didn't fall asleep, which was good.
Did you go for a pee or?
I didn't have a pee either. Awake, 3 hours. We went to an everyman, which is great because you have little sofas. So remember, my wife was sitting on a sofa.
Yeah. And
I wasn't kicking anybody, or thrashing out. Plenty of leg room and stuff. Lovely. I did have a bit of a cry, though, before it started.
You're crying at Odyssey?
No, before there was a Cadbury's advert on.
Oh, right.
It made me cry. It was really weird. Picture the scene. This girl's alone in a room in Kuala Lumpur, as it turns out.
Where are you going with this, Dave?
And
It's not the Flake advert. It's from the 80s, is it? Do you remember that?
Yeah, I do, yeah. Quite raunchy, wasn't it?
It was.
It was nothing like that.
Okay, sorry.
This girl's alone in a room in Kuala Lumpur, and she gets a package from her sister.
Ooh.
So she rings and leaves a message on the answering machine of her sister. She's all alone, and she says, "Yeah, you shouldn't spend your pocket money on me. I really appreciate the thought, but, you know." And she sent her a bar of dairy milk. Opens the envelope. Says, "You can leave me a message. I'll probably be asleep, so at the other end of the world." Opens the envelope, and there's a bar of dairy milk, and there's just one chunk missing. Her sister's nicked a chunk. And it got me quite emotional, you know, and the sisterly love and all that. Fantastic. And I think the lack of dopamine makes you a bit more emotional, doesn't it? There's actually a name for it. If you laugh uncontrollably or cry uncontrollably, a thing in Parkinson's is called pseudo-bulbar effect. Some people get pseudo-bulbar effect. PBA, which means you can't stop laughing or can't stop crying.
When you
unusual.
Laughing at inappropriate times, is that part of that as well?
I think laughing at inappropriate times can count. Yeah.
Because we've
we'll have to look into it more, but yeah.
Yeah, we've had a few guests on, and they've laughed at inappropriate times, and I thought, oh, that's a bit odd, but maybe that's what you're referring to. Certainly, the emotional thing, I get a bit teary at adverts and movies and things, and nothing wrong with a good cry, Dave. Nothing wrong with a good cry, right? Kind of healing.
I was trying to hide my tears from people in the cinema, but I thought, no, it's fine. I'm allowed to cry at something sad, or happy. We're emotional people, aren't we?
We are. I bet if you ask them, they'd rather you keep the chair than... But fair enough, yeah. Do you know what I've been doing, Dave?
What have you been doing, Kieran?
I've been bird watching. Got a bird feeder.
You're a twitcher?
Oh, is that what we're called?
Yeah, twitchers, yeah. What have you been twitching recently?
Oh, some blue tits and finches and my favourite, the woodpecker. It's very nice because I've stuck a camera out there as well. So I can get nice close-up shots and photos and videos and stuff. It's really, really cool. I'd never been fascinated by birds until recently, and I love, especially morning time, because there's only respite from the heat at the moment. Go out there and have my breakfast and my tea and listen to the birds and watch them. It's very peaceful. It's very nice.
We've got a guest today. Tell us a bit about him.
Ash is he's a great guy. I've met him a few times, and he's an expert on DBS. And I thought, I've done a few episodes of DBS and last year, and obviously I was telling my story with DBS, and you'll potentially go down a DBS route. So I thought this is a nice time to revisit the topic with an expert in the field from Oxford. We had a very interesting chat with him, didn't we, Dave?
Yeah, I did. Dr Ashwini Oswal, Honorary Consultant Neurologist at John Radcliffe Hospital in Oxford. He's a researcher, he's a neurologist, he's a top man. Let's hear from him. Dr Ash Oswal, welcome to Two Parkies in a Pod.
Thank you. Pleasure to be here, and thank you for inviting me.
Just tell us a bit about yourself, how you got involved in DBS.
Yeah, so I mean, I'm a neurologist by background. I sort of specialize in movement disorders, Parkinson's disease, and deep brain stimulation, and I do that at the John Radcliffe Hospital in Oxford. But I also wear another hat, whereby I'm a researcher and a scientist, so really a clinician scientist. And in that role, what I do is I lead a research group where we conduct research into Parkinson's disease and related conditions to try and sort of better understand the brain networks that are responsible for driving these conditions, hopefully with the aim of getting better understanding, better insights that could inform new therapies. So that's really kind of my angle.
I'm just going to rewind back to earlier in your life, because we had a conversation recently over dinner. It's one of those small world stories where turns out we went to the same school, remarkably.
Yeah.
We were not at the same
Young
time.
Offenders Centre somewhere, Kieran.
Well, actually, not far off. That was the subject of our conversation over dinner, actually. Comparing notes. No, it was a very average school. And we didn't actually overlap in terms of our time there, but we overlapped in terms of the teachers that we had, and we were reminiscing, and we were mentioning teachers' names that we hadn't heard for years, and small world, because it's actually quite a small school. But the reason I mentioned that story is that you told me that, and if you don't mind me saying this, you said as a kid you were quite an anxious kid, and you wanted to understand the root of that anxiety, and that's what motivated you to get into the world that you're in now. Is that right?
Yeah, partly. I mean, I think as a kid growing up, and I'm talking about myself here, but maybe this applies to others too. You're kind of constantly faced with new things, new emotions, new kind of feelings, new situations. And partly that can create anxiety, which is really sort of a very kind of physiological, well, it has a very sort of strong physiological effect on the body, affecting your heart rate, your blood pressure, and so on and so forth. And I think that did affect me as a kid. So my kind of way of dealing with that, I think, was to try and understand a little bit more about where it was coming from. So try and understand a bit more about physiology and biology. And partly, I think that did kind of provide me with a sort of a natural path to going into medicine, to kind of understand where these sort of feelings and emotions and physiological sort of phenomena arise. But actually, I mean, another reason, probably even a bigger reason, to be fair, was actually the fact that both my parents are doctors, and as a kid growing up, for most kids, or for many kids, the parents are a sort of their biggest inspiration. Really, that kind of also nudged me in the direction.
I just wonder whether being an anxious child's made you a bit more of an empathetic doctor. Do you think it has?
Possibly. You'd have to ask my patients.
We have actually. No, I'm joking. I'm sure you're very personable, Ash, having met you a few times now. So we're here to talk about DBS. So I think you're the right guy for this, specifically when it's the right time for DBS. Can I start with the 5-2-1 rule?
Yeah.
And could you explain what the 5-2-1 rule is to our listeners, and whether you actually think it's a good rule of thumb or not?
Yeah, I mean, the 5-2-1 rule is really a rough guide that kind of gives you some idea about when DBS might be appropriate for someone. But it's not a rule that we strictly have to adhere to, or people strictly have to adhere to. So the idea is that, if somebody's taking Parkinson's medication 5 or more times a day, and despite them taking it 5 or more times a day, they're still sort of having significant off periods, greater than sort of 2 hours in duration throughout a day, that may or may not be associated with more than an hour of dyskinesia, i.e. 5 lots of medication, 2 hours of off time, and an hour of dyskinesia, then that might be a good time to start thinking about DBS. Really, more than anything, it's probably just a rule of thumb. So although it can kind of give you some sort of guide, it's not necessarily definitive.
Yeah, I mean, it's hardly scientific in that respect, and obviously you'd always be guided by your neurology team, the likes of yourselves. But it is quite a handy, rough guide to know, because we get a lot of people that particularly early, fairly newly diagnosed, almost jumping to what is an advanced treatment. We'll come on to the terming advanced treatment because I don't think it's actually very helpful for a few reasons. And likewise, probably the bigger cohort of patients that I believe are leaving it too late.
Yeah.
And that's why I think having some sort of guide that people can understand, 5 or more pills a day, 2 hours or more of off time, 1 hour or more of dyskinesia, and I would say problematic dyskinesia, then that is a useful, very rough rule of thumb to understand whether you are in the right position for DBS or not. Now, I fitted that category when I had my surgery last year, but I fitted that category for several years, and I was in danger of leaving it too late. And I'd say, Dave, you think you comfortably fit in that 5-2-1 rule, right, Dave?
Yeah, I think so, yeah. I'm just wondering, I'm on Entacapone. I was on Entacapone and Opicapone now. Is that a sign that I need more advanced treatments? And is that a bridge to DBS?
Yeah, it's a really good question. First of all, Entacapone and Opicapone, they're COMT inhibitors. So what that means is that they're there to prolong the effect of the dopaminergic medication that you're taking. Now, when we start to think about giving Entacapone and Opicapone is when people start to have off periods, i.e. kind of you're wearing off towards the end of medication doses and you feel like you need another dose. That's when we start to think about Entacapone. And really, like, one of the indications for DBS is when people start to have motor fluctuations. So motor fluctuations includes wearing off in between medication doses. So, by virtue of the fact that you're on Entacapone and Opicapone, that kind of suggests that you're wearing off in between doses. At some point in the future, we may need to think about DBS, not necessarily, but it's something that you may want to have a discussion with your neurologist about. That being said, Entacapone and Opicapone can be very effective for a certain proportion of patients in adequately controlling those off periods. So some people might find that with Entacapone or Opicapone, they can go for a long time without needing anything else. So you were going to say something, Dave?
I was going to say, is that a short-term fix, Opicapone, or is it, a long-term thing?
I guess it's different for different people. For some people, it's a short-term kind of fix, and they still have troublesome off periods despite Opicapone or Entacapone. But the main problem with these things is that they're going to usually make the dyskinesias worse. So Opicapone and Entacapone, more often than not, I would say, will trigger dyskinesias if dyskinesia is a problem.
Yeah, it's a catch-22, isn't it? When you're at that stage where you're getting those fluctuations, you're getting the off periods, you take some additional medication, but then that additional is causing that dyskinesia. It becomes a tough choice a lot of the time. I think when you're at that stage, certainly that's what really brought it home for me. My choice was either an off period or a dyskinetic period. Yeah. And collectively, they were far outweighing my on periods and good on periods in the day. So I think that's probably another useful rule of thumb. I guess by extension, if you've been prescribed amantadine for your dyskinesia, that's probably another good indicator to start at least thinking about DBS, right?
Yeah, I think that's a reasonable point at which you'd want to think about it, particularly if dyskinesias are troublesome and you're needing higher doses of medication to control your off symptoms as well.
Would you agree with what I said earlier, that people are quite wary when you first mention DBS to a patient? What's the typical, I know it's very difficult talking averages, but what kind of response do you get from patients?
I mean, more often than not, people have kind of heard about it potentially, or kind of done some research about it, or they might, through a local group, know somebody who's been through it. So it's kind of, on the whole, rare for someone not to have heard about it. But that being said, there are patients with whom you discuss it for the first time, and really kind of falls into kind of three categories, I think. You get people who say, absolutely not. I'm not having a burr hole drilled into my head and going down the route of neurosurgery. That's not for me, come what may. And that's fair enough because, it's a personal choice. For some people, the thought of DBS terrifies them. And that idea of them undergoing brain surgery just causes so much stress and anxiety.
Yeah.
The level of stress and anxiety is worse, almost kind of worse symptoms that they have.
Yeah.
And then you get kind of, actually the most common kind of scenario where patients would sort of be of the mindset that, oh, that's interesting, maybe I should think about it. But at the same time, they're a bit worried or they're a bit understandably concerned to undergo this big surgery. And that's probably the most common scenario. And then on the other hand, you've got patients. So for example, the other day we had a patient with tremor, whose tremor was just so disabling in terms of their activities of daily living and quality of life. They essentially just said, yes, please, this is what I need.
Desperate.
They were desperate. Exactly.
Yeah. Can I just point out, I was each of those three people at different stages. So I'll tell you my experience. When DBS was first mentioned to me, I was horrified. And this is about 5 years ago. And I'd been taking Entacapone and Amandatine for several years before that. So in retrospect, I think it was mentioned to me and raised at the right time. But in my mind, it was positioned as an advanced treatment. And I thought advanced treatment meant I've got advanced Parkinson's. I thought it was the end of the road. And I thought there's nothing else after that. Taking levodopa, forget DBS, there's nothing else for me. I was in my 40s at the time. And I got freaked out by it, to be honest. I remember the neurologist at the time, when he mentioned it to me, my immediate reaction was, no way, Jose. Partly because his name was Jose, actually. It was a bit ironic. But on a serious note, I just thought, no, far too early. Then things got even more problematic for me over, fast forward a couple of years, when dyskinesia was disabling for me. The off periods were horrific for me. So at that point, I got referred, went through the various process, and that took me 2 years from initial referral to surgery. And by surgery day, I was the third guy. I was, bring it on. Give me it now. I want to wake up and I want to feel vaguely normalish, or at least give me some relief. So I think it's more, well, in my case anyway, I think it's more a case of stages rather than distinct individuals, if that makes sense.
Yeah.
I'm just going to read you some stats, if you don't mind, because this really does bring it to home. This is from a paper in Canada. 15 to 45% of patients hesitate, delay, or ultimately decline DBS when initially offered to them. Clinical data shows that while many are considered ideal candidates by the neurologist, a significant portion back out before the procedure. 15% of approved candidates outright decline the surgery once it's formally offered to them. Up to 45% fall into a reluctant group when first presented with the option. They experience heavy anxiety, as you were saying, and delay the procedure for months or years before either agreeing or declining permanently. Up to 45% of people are falling into that category. It's amazing, isn't it?
Mm.
And I mention this because not only is there's a right time to consider DBS, the window closes at a certain point as well, doesn't it, Ash?
It does, based on somebody's disease stage and progression, in the sense that in people who've got sort of more advanced symptoms, we're talking about kind of cognitive impairment or significant issues with gait or walking, such as falls or freezing leading to falls and other gait issues, then we start to get more worried about whether we're going to do more harm than good by stimulating deep brain areas, essentially.
This is also echoed by way of research in the same study, which said 74% of patients that decline do so because their fear of complications, the psychological barrier of undergoing brain surgery awake alongside fears of infection, brain bleeds, and permanent cognitive decline. So just going back to red flags that you listed there. So you mentioned about balance, falls, cognition. Dave's just had his cognitive test for DBS, by the way. And he agrees with me. It's very full-on test,
How
very thorough,
stressful
let's
was that?
say.
Yeah.
Yeah. What about speech? Because I was worried about my speech.
Yeah.
Now, I don't know if I'm an exception or not, but my speech has actually got better.
Okay, amazing.
But
Yeah.
is that common or not?
Yeah, it's a really good question, actually. I think in a good number of people, if they're assuming that the surgery goes well, the electrodes are well placed, you're easing their kind of motor symptoms, you're kind of improving overall motor function. You probably would see an improvement in speech. So I don't think it would be sort of uncommon to see an improvement in speech with overall improved motor function, overall improved movement. But at the same time, kind of, if you're kind of stimulating areas or tracts or fiber tracts that are just outside the subthalamic nucleus, the STN, which is where the electrode is going to be put in, then you could potentially make speech worse as well. So making the kind of side effect of making speech worse is a very real side effect. And that is something that a lot of people do report with DBS as well. So we can't always promise to make speech better. And sometimes it does get marginally worse. So that's kind of something that we do have to be aware of as well.
Ash, can you tell us how DBS actually works?
Yeah, that's that. I think that's
Good question.
That's the $1 million question. We don't really fully understand or know how it works. So we know that the areas of the brain where we put electrodes in Parkinson's disease, the basal ganglia, we know that kind of their function changes as dopamine is lost within the brain. So in Parkinson's disease, there's a lack of dopamine, and as that sort of dopamine is depleted, we know that these basal ganglia circuits, the deep areas of the brain, their activity changes. And kind of initially, the surgical treatments for movement disorders were to lesion various deep brain areas. So, but by performing operations such as thalamotomies or pallidotomies. So you'd essentially
Which is what Michael J. Fox had. Yeah.
Yeah. So you'd essentially put a lesioning apparatus deep into the brain and burn a hole into the thalamus or into the pallidum to kind of essentially knock that area out and assume that the rest of the circuit would start functioning a bit more correctly. Then kind of in the late 80s, French neurosurgeons and others had this observation that you could stimulate deep brain areas, and rather than lesioning them, by stimulating them at high frequency, you would essentially kind of be causing a reversible lesion. So the idea is, if you stimulated a structure at a very high frequency, it would be blocking its activity, but not irreversibly lesioning it. So that was kind of the initial thinking. But then we've got sort of much more sophisticated with the way in which we conduct research, and you might have come across adaptive DBS. We found out that there is abnormal activity within these deep brain structures at kind of what's known as beta frequencies. So we're talking about sort of 20 hertz. And one of the ideas is that DBS might suppress that, but it's still kind of very much at the sort of research stage.
So you mentioned adaptive DBS. Just for the layperson, what is it? What's it doing? What's it not doing? It's reading your brain signals and adjusting the stimulation accordingly is my very simple understanding of it. Is that right?
Yeah. Hopefully I can explain this a bit better than the question about what DBS is doing. But I think the best analogy is probably a cardiac pacemaker. So if you imagine a sort of a pacemaker for the heart, that's not going to be stimulating all the time, right? Because you wouldn't want it to give shocks or stimulation all the time. It's only going to be stimulating when it detects some abnormal heart rhythm, and it will stimulate to kind of correct that abnormal heart rhythm. So that's how kind of cardiac pacemakers work. And it's really the same kind of thing for the brain. It's just conventional DBS, as it stands, involves continuously stimulating the brain. We continuously stimulate the brain at 130 hertz, and essentially we don't stop. So that continuous stimulation is there during the day, it's there during the night, it's there when you need it, it's there when you might not need it as well. But what adaptive DBS does is that it kind of senses the brain activity. So rather than stimulating all the time, it
Right.
only stimulates when that brain activity suggests that symptoms are going to get worse. And what that also invariably means is that the stimulation goes down at night because that brain activity goes down during sleep.
Fascinating. That's a particular area of interest for you, isn't it? You've heard my view on it, or my experience on it rather. Didn't quite work for me yet, and it is just a software thing, isn't it? It's not. You don't have an adaptive DBS surgery as such, do you?
Yeah, that's right. It's purely a kind of a software thing that certain devices allow. The surgery is no different in terms of what it involves.
Which patients have the biggest improvement with adaptive DBS
That's a really good question.
and DBS in general?
Yeah.
Yeah, I think in short, we don't have a good answer to that as yet. So who's going to benefit from adaptive DBS versus just standard continuous DBS? I think the truth is we don't have a good answer. And over the next few years, we're going to get a clearer understanding of who's going to benefit most. Right now, what we're seeing, we can kind of improve good on time to an extent with adaptive DBS over continuous DBS, but it's only in some patients, not in everyone. Um, and the other thing to bear in mind also is that with adaptive DBS, it does involve more programming visits, so more coming to the hospital more frequently for the patient, and also kind of
For hours at a time, often, right?
and more clinician time, because
Yeah.
you need to kind of very carefully look at that brain activity
Yeah.
and decide on the right kind of settings for the device. It's about kind of finding that sweet spot for the stimulation, and that just takes a lot of time.
It took me 8 programming sessions, best part of a year to in my case. And I'm on a setting now that's just working for me. I've found the sweet spot, but it's taken hours and hours and hours. And they're quite grueling sessions. So if you decided to have DBS, don't just focus on the surgery as often and naturally patients would, but there's stuff that goes on after that requires quite a bit of tinkering, quite a bit of clinic time, quite a bit of that you're off medication at the same time. So you've got to be prepared for this stuff to a certain extent. In my view, it's worth it. In answer to the question about adaptive DBS versus standard DBS, my view is adaptive might be the icing on the cake for some. The jury's out. It may well be, but the cake itself is DBS.
The other thing I should mention also very briefly is that normally when we do DBS, we wouldn't start somebody on the adaptive mode after their surgery, bring them back for their first programming appointment, usually sort of 6+ weeks after the surgery, and then kind of activate a continuous mode, see what the response is to that. If somebody's had an amazing response to that, then, there's a good case for just leaving it be. But if there are still issues, then you might start thinking about adaptive DBS as kind of follow on.
I think a lot of this is case by case and also centre by centre as well. So my adaptive didn't get switched on until 9 months later. And in retrospect, I was probably doing all right without it and didn't really need it right now. But that might change in the future. Can I just go back to Dave's question? So standard DBS, what's the ideal sort of patient that would have the standard garden variety DBS? Who would benefit most from it?
Yeah.
Aside from the criteria about the off periods and so on, or is it just purely that you're looking for the fluctuations, the off periods of dyskinesia?
Yeah, I mean, it's usually we're mainly looking at the motor fluctuations, off periods dyskinesia, or medication refractory tremor. And if somebody's got medication refractory tremor, depending on how bad their other motor symptoms are, you might consider either the thalamus as a target for DBS, or the subthalamus nucleus, or the STN. So those are the kind of broad criteria that you'd think about when considering somebody for DBS.
Which symptoms respond the best to DBS? Does it vary patient to patient?
Yeah, it does vary patient to patient, but things like sort of tremor tends to respond quite well on. So we ask patients whether their tremors improved after DBS. I think the majority of them will say yes, there's been an improvement in tremor. So if there's tremor that's not responding to medication, usually that's something we can improve. Again, other kind of off symptoms, so kind of slowness of movement and stiffness, that off kind of poor mobility does respond quite well as well. So off symptoms can respond. Sometimes even off freezing of gait responds quite well to DBS as well. So patients who've got sort of freezing of gait, but it's off medication and in response to medication, on the whole, they tend to do quite well with DBS.
Does it help with swallowing as well?
It can do, but we never sort of promise that it's going to help with swallowing. And usually if it does help with swallowing, it's one of those things that is probably a result of overall improved motor function. But I mean, if somebody had significant swallowing difficulties, I would never say that DBS is going to definitively help them.
The way it was sold to me, if I can put it like that, that's unfair. It wasn't sold to me. It was discussion. Was slowness, stiffness, and tremor is likely to have a positive impact on probably dyskinesia, and all that has been true in my case. It was positioned as a motor symptom treatment, but what I have found is that my fatigue has improved, and that might be because I'm moving around a lot less. My sleep has improved because I'm going to the toilet less at night, so my nocturia has reduced. My anxiety has reduced because I feel more independent, I feel more confident in my mobility. So there's been a lot of indirect benefits, aside from the slowness, stiffness and tremor that DBS is often positioned for, that I'm getting, and it's very tangible for me, and it's very real. I feel a lot better now in many respects than I did just over a year ago. I'm just going to put this in perspective by asking you about a theory that you mentioned to me and another piece of research that I'll read out to you. Your theory is, I'm going to put words in your mouth just for a minute, that you think DBS potentially might be neuroprotective, so not just improving the symptoms, but doing actually something to the underlying condition itself. And I'll just read this excerpt from a study to you. This is from Nature. A few weeks ago, a new paper has been published. A retrospective cohort study suggests that deep brain stimulation may offer lasting benefits for people with Parkinson's disease beyond improving symptoms. Researchers found that patients who underwent DBS were less likely to require long-term nursing home care, had a lower risk of death, and experienced lower healthcare costs compared to those who did not receive the therapy. The study also highlights the need to improve access to DBS, as not all patients who may benefit from the treatment have equal access to it. So that's a paper that's been published in the Nature journal. But you're also working on your own research that's evidencing similar things. Is that right?
So we haven't been working on that specific question about, the epidemiological aspect of things, comparing patients who've had DBS versus no DBS and following them long term. That's not something that we've looked at, but it's really interesting to look at, because I think these questions are really important. And it's really important for us to get a clearer answer on these things, so that we can better inform patients who are thinking about DBS. In terms of whether DBS is neuroprotective or not, the jury's still out there. We can't sort of jump to any definitive conclusions on this. The safest thing and the most honest thing to tell patients and people who are thinking about DBS is, right now we don't have any strong evidence to suggest that DBS is neuroprotective. But there is some research that highlights that DBS may have benefits beyond improving just quality of life. It is very interesting. And my colleagues will say different things as well. So, I was speaking to two eminent neurologists, won't name names, but they both said very different things. One was convinced that DBS, not neuroprotective, doesn't kind of change the underlying pathology of Parkinson's disease. And another one sort of was very much of the opinion that if you do it early enough, then you might be able to impact or alter alpha-synuclein, which is one of the pathological molecules involved you might be able to alter the way in which it aggregates. In all honesty, we don't know enough to give you a firm answer about this, but I think this
You
is
got a
an area of
hunch. Can we
interest,
put
and
it like that?
I'd like to do more research into it.
Yeah, fair enough.
It makes sense that you may live longer with it because, you're not going to fall. You're walking so much better than it was. Your movement's much better. The things that
The
affect
swallowing
you,
thing that you mentioned.
swallowing,
Yeah.
all that sort of thing.
Yeah.
Things that could be fatal for Parkies. It sorts it
Yeah.
out for short term anyway.
That does make sense, doesn't it? Yeah. You can believe that, can't you?
Yeah.
Yeah. What else in the DBS world should potential Parkinson's patients be considering when entertaining it? Can I suggest that some people maybe there's a case that we have to manage expectations in terms of that group that you described that just want it,
Yeah.
and think it might be offering a bit too much than it actually is. How do you deal with that?
Yeah, I mean, I think when we offer any treatment that involves an invasive procedure, we want to offer something that is likely to improve quality of life and overall function. And when it does, it's amazing, it's great. But then, when it doesn't, it can be a challenge also. And, fortunately, most of the patients that we tend to see do derive benefit from DBS. Like you, Kuhan, it's amazing to see someone whose kind of life has been transformed by the procedure. But when it doesn't, it's kind of difficult. And I think you've got to ask yourself why. So you've got to carefully ask yourself why something isn't working as expected. Is it because, for example, the electrodes aren't quite in the right position, which, does happen. Fortunately, nowadays we've got sort of excellent imaging software that allows us to sort of visualize the electrodes in kind of 3D space and see where they're sitting. And if things are not quite right, then we can kind of map that to the clinical effects and then think about whether or not a particular lead or electrode needs to be repositioned to improve things. So that's kind of one thing that we can do to manage it. Another thing that we can do, again, with the imaging is to try and optimize our stimulation parameters. So actually nowadays, one of the device manufacturing companies has a very nice software that actually uses AI to give you automatic stimulation parameters. And they're very different to the ones that you might have selected clinically as well. So
this is the Boston one, right?
Exactly. Nowadays, you've got so many contacts on these electrodes that it can be quite a time-consuming procedure to kind of go through each of them and find, the various combinations and permutations that give you the best clinical outcome.
And there are a lot of permutations, aren't they? That's why those programming sessions are so important, so lengthy.
Huge jumps. Actually, with some of the newer contacts, if you consider sort of pulse width, the different parameters you can tweak, it's almost kind of impossible to test every single kind of option. Having some kind of tool to give you, at least guide you, give you some sort of foundation from which you can then sort of tweak things is actually quite helpful. But as you say, the other thing is sort of managing expectations as well.
One way or the other.
Yeah, no. So when it comes to managing expectations, it can be tricky. The important thing is to, I find is just to be really honest about what you think can be improved and what may or may not be improved and what can't be improved. And, as long as you're clear about that at the outset, then it kind of makes things a little bit easier.
Yeah. But, we're humans at the end of the day, right? You can set the expectation as diligently as I'm sure you would do. But at the end of the day, people are going to hope, let's say, at the very least. And how do you deal with patients when you see you've guided them on this DBS journey, they've had the procedure and it hasn't gone well? That must affect you, presumably, right? I mean,
yeah, for sure. It does affect you. And in those cases, it's really important to see that patient more frequently, bringing them in, seeing how they're getting on, regular visits, regular follow-up, regular kind of catch-ups to kind of give you a bit more information about things. I think that's really important. And that's what sort of I tend to do. And, I suspect many of my colleagues would do the same thing, but kind of increasing the frequency of the follow-up so that you can kind of get a better understanding of what's going on, track things a little bit better. And, hopefully just offer some potential solutions to things.
And conversely, it must be very satisfying to see when people's lives are being transformed by this treatment, right?
Yeah. Funnily enough, like you say, I mean, the people who've been, for whom it's had a transformative effect, you might see them once or twice, and then they go away and they don't want to come back until until they need to. So it's actually the people.
That's the way it should be, shouldn't it?
It's great. It's fantastic. But when people run into more difficulties, that's when you end up seeing them more. So you kind of almost put more emphasis on that.
Oh, I see it. Fascinating.
Can I just ask, does DBS rule you out of any other treatments? Stem cells we're talking about now.
Good question.
Really good question. So, I mean, all of the stem cell stuff has essentially been thus far restricted to clinical trials, i.e. research studies. So, there was a recent stem cell paper published by Roger Barker's group in Cambridge, I believe.
We just did an episode on that.
Yeah, okay, perfect.
Yeah.
I mean, if that's something that you or somebody wants to get involved in the future, it would kind of all depend on the trial eligibility criteria and so on and so forth.
Most trials will exclude people with DBS, is my experience. But once it's out of trial and deployed, let's say fast forwarding 5-10 years, stem cells or gene therapy comes to fruition, is fully deployed, then yes. But I think Dave's question is more like, aside from the trial dynamics, is it actually physically possible to have stem cells implanted or gene therapy performed, as well as having the DBS implants in your brain? Is that possible? Do they all fit?
Yeah, I mean, I think from a technical standpoint, I don't see any kind of reason why you wouldn't be able to have stem cells implanted in the future if that was offered as a clinical therapy.
It's a different part of the brain, right?
Yeah, it's a different, they'd be put into a different part of the brain. But, depending on where you're implanting them, you'd have to consider the location of the electrodes and, the fact that there's a device already in situ and so on and so forth. And, the trajectory you're going to take to implant them. It would probably involve a discussion with the surgeon who's doing the surgery to kind of discuss the technical feasibility. But I don't imagine that it would necessarily completely preclude the idea of having stem cells. Yeah.
And you wouldn't put off DBS because stem cell technology is improving?
I don't think that the stem cell technology is going to be available for clinical use within the next few years. I think it's going to take a bit longer than that.
Yeah, and ultimately that is what it came down to for me. All this stuff, it sounds great, but it's years away, if not a decade or so away. And you've got to make a choice. I'm 51 now. I don't know how long I've got left, but you've got to decide, like, how long are you going to wait for something that might not happen versus a treatment now that's established, that's been done 200,000 times worldwide. If you're a betting man, the numbers on your side, particularly if you're the sort of patient that I am, the sort of patient that Dave is, you're otherwise fit and healthy and you don't have other complications. You fit the bill. If you fit the bill and it's offered to you, and by the way, if it is offered to you, that is a good indication that you are the right sort of patient. At least go through the steps I always say to people. Do the levodopa challenge, have the discussion with the surgeons and your neurologists and all the rest of it. Back out afterwards if you want to, but at least consider it. Ash, let me ask you a quiz question if you don't mind. Then Dave's got some more quiz questions for you, but I'll give you mine. How many people, of the 166,000 people in the UK living with Parkinson's, how many would you guess are living with DBS today?
Oh, God, that's a really good question. Yeah, I mean, how many would I guess that are living with DBS in the UK? I would say less than 5,000.
7,000. Yeah.
Okay.
So less than 5% of the Parkinson's population. That's a very low number, I think, for a treatment that's very effective.
Yeah.
Part of it is not everybody has access, right? It's not equal access. We're very fortunate being in London. If you're in Bristol or Newcastle or one of these places, then you're fortunate. And even if you are, the wait times are still very long.
Yeah.
But also those barriers that exist, and often they're quite legitimate barriers in patients' minds about they're fearful or some version of fearful, because it is brain surgery after all. If we can just help address them through conversations like this, through sharing experiences like this, both patient and clinician side, I'd love to be seeing that number grow over the years, because I think it's a fantastic treatment. And what's going on in adaptive and beyond adaptive, because you're in that space as well, in terms of the next generation of DBS, it seems very exciting to me and far more of a smarter treatment than just the pills.
Yep.
If we're recording this podcast in 10 years' time, what do you think Parkinson's surgery will look like then?
Yeah, I think DBS will still be around in 10 years' time.
Okay.
So if you compare where we are now with 10 years ago, I mean, right now, we've got adaptive DBS approaches, which are kind of another sort of weapon in our armory, so to speak. We've got much better imaging. We've got much better imaging, which leads to better programming. We've got the segmented contacts. We didn't have that 10 years ago. And, that gives you more programming options, more complexity, but, more programming options. And again, that might be helpful for a proportion of patients. What we've done over the past 10 years is take an effective treatment and make it safer and more effective, in an incremental manner. But really, like you're saying, Kuhan, I think an important part of this is kind of ensuring access to therapy and ensuring that the people who do benefit get seen by a DBS specialist and at least have that conversation. Because having these conversations and educating really is going to be the way to increase access. And it may be that people who are likely to benefit don't want it, but that's also fine. It's about having the conversation and sort of, and highlighting that this is there if you need it.
Dave, have you got some quick fire questions for Ash to finish on?
I was just going to say, Ash, before you disappear and find a cure for us, quick fire questions for you. Researcher or clinician?
Clinician.
The biggest myth about DBS, what is it?
The biggest myth is it's a very high risk brain surgery.
Say risk.
What's the biggest mistake patients make?
Oh, that's a good question. The biggest mistake patients make.
Would leaving it too late be an answer?
Yeah, but that's not necessarily a mistake that patients make. I guess it's kind of, that's on the clinician, isn't it?
Really? Oh, right, yeah. Fair enough, yeah.
Lifestyle. So just simple lifestyle measures have a massive effect. And it's not just for Parkinson's disease, but in general. How much we sleep, how much rest we have, ensuring that we don't take too much stress. I think that's all kind of really important. Gut health as well. Yeah.
Go on, Dave.
Okay, we've got two more for you. One is, if you think you're suitable for DBS, what's the first thing you should do?
Speak to your neurologist about it and get a referral to a DBS centre.
Finally, are we entering a golden age for Parkinson's treatment, do you think?
I think we're entering a really exciting era. Stem cells, like you're saying, definitely very interesting. DBS is also kind of a very interesting area. And I think we need to get drugs that slow the progression. And I think if we can get there, then it would be an amazing thing for the Parkinson's community.
Wonderful.
Fabulous.
Thank you very much for your time today. You've taken us through and answered the question, when is the right time to have DBS? And you've answered plenty more. Wonderful.
Pleasure. Hopefully I've been of some use.
Well done. I found that really fascinating, Kuhan, really fascinating.
Really interesting guy, really interesting chat. Like I said, we've done DBS episodes before, but there's always something new you can discover. And I think he helped answer the question about when is the right time to have DBS, because that's something that comes up a lot, and we haven't really tackled that side of it before. So I'm pleased he gave us the overview. There aren't any easy answers, though, unfortunately, right?
No, there aren't. The 5-2-1 rule I like, though. That was really interesting.
Handy rule of thumb. But of course, there's so much else to consider.
It's changed my mindset a bit, because I was thinking it was last resort, DBS.
How are you feeling about your potential DBS journey now? Having had that discussion, having been through some of the tests?
A bit anxious about it, but at the same time, I'm quite excited about it. If anything, it's made me want it more. I think the whole thing of having a computer in your body, it freaks me out a bit. But you've coped with it brilliantly, and you don't cope with a lot, really. So
No, exactly. So if I could do it, Dave, you can.
you're not whinger most of the time, so you don't complain about it at all. So if you can cope with it, I can.
Exactly. And to be honest, Dave, I don't notice it. I don't notice it at all. I mean, I've got the scars and everything to prove it, one there and one there, but you can't really tell from the outside, and to look at, you can't really tell. And I can't, day to day, I didn't, sometimes you almost forget about it. The only time I don't is when I have to charge up every week. And now I'm on stable settings. I don't carry the controllers around with me at all. So it's just like charging up a gadget. That's all you have to do. I'm simplifying it a little bit, but
You don't feel it in your brain or anything, do you?
no, I'm kind of like, if I touch my head, then you might sort of think, oh God, there's stuff in there. But, and I keep saying, don't focus on it, and if you don't, and get on with life, honestly, you don't notice it. I don't know what to compare it to, but all I can say is day to day, I don't notice it at all. And the thing that I was worried about was I'd wake up from the surgery and I'd be a different person.
Yeah.
And it's not like that. I'm me. I'm just, a slightly more able version of me.
It doesn't change your personality at all, does it?
No. I just remember from years ago, I used to watch stuff about lobotomies and brain surgeries and people being bit.
One flew over the cuckoo's nest.
Yeah, exactly, that sort of thing. And I didn't want to be like that. I wanted to be me. Like I said, I'm more me now than I was before.
You're the greatest advert forever.
Yeah. I'm involved in these DBS groups on Facebook and WhatsApp and things like this. And more often than not, the experience is positive. And I still haven't met a person where they'd regret the decision to have it. You might get people that are saying it's not perfect, but ultimately, I've never met anybody that's regretted having it. Yeah.
Let's do it.
And let's do some amazing people as well, right?
Yeah, amazing people doing amazing things.
People with Parkinson's do amazing things.
Kicking off with this one, Sharon Osbourne has been splashing the cash raised from the Black Sabbath Back to the Beginning concert at Villa Park. Some of the money went to cure Parkinson's. A few quid will be used to recruit research participants at the Queen Elizabeth Hospital in Birmingham. Andy Simons from the charity can tell us a bit more.
Money is going to fund, first and foremost, it's going to power research forwards, which is a global mission. But yeah, Sharon and Ozzy were very clear they wanted it also to specifically benefit people in Birmingham and in the West Midlands who are living with Parkinson's. So yeah, the funds raised will support two and perhaps more trials in future that are going to be recruiting from the Queen Elizabeth Hospital in Birmingham and from two other sites in the West Midlands to make sure people in that area have the chance to be part of the research. Ozzy's one of the biggest global superstars you can imagine, certainly the most famous person with Parkinson's. So it was fantastic for him and Sharon to support us and for the family to support us. You can imagine we don't get chances to talk to the heavy metal music fan base much as a scientific research charity, but Parkinson's doesn't discriminate. So fans of all music genres are equally affected by Parkinson's, and for us to have the chance to reach new people, more people, make the research go faster, means a huge amount, and we're very, very grateful.
Top man, Andy. Top man.
Really good. Heavy metal, helping cure Parkinson's.
People with Parkinson's do amazing things.
A new partnership between Parkinson's UK, Table Tennis England and Parkinson's England Table Tennis is aiming to get more people with Parkinson's to play the sport. It's a lot of P's in there, isn't it?
A lot of P's.
P's and T's are hard.
At one point you were like, pickled pepper.
I know. Table Tennis England, Parkinson's UK, England Parkinson's Table Tennis. Could we have very easier names, please?
Yes, please.
Anyway, it's trying to get more people to play table tennis, not ping pong. And more information in the show notes if you want to get involved.
So why is it not called ping pong? I thought it's a...
I think ping pong... Isn't it ping pong when you have to bounce first before it goes over the net?
I don't know. But it's a great thing for Parkies.
It goes ping pong.
How does it go, Dave?
All right. I don't know, ping pong. Right, last one here.
People with Parkinson's do amazing things.
Kevin Campbell has put a note on the Parkinson's Warrior Facebook page. wondering if his newfound love of darts will help with his dexterity. It's got me walking back and forth to the board and aiming darts at targets, trying to improve my throwing, and hopefully I'll hit what I'm aiming for eventually. It'll also help with his arithmetic, won't it?
It will, yeah. Well done, Kevin. From Arsenal striker to a darts player, right?
Top man. He said he thought about it that one morning that he wanted to play darts, ordered all the kit. He's got this darts stage in his house now.
Well done. I thought that might catch your eye, right?
Yeah, exactly. I love the darts. If you're doing something amazing, why don't you get in touch with us?
Please do at hello@twoparkiesinapod.com or on Apple Podcasts, Spotify. Go back and listen to some episodes. Give us a rating. Give us a review. Subscribe if you haven't. And I think that's all we've got time for today, isn't it, Dave?
I think so. We'll see you soon. Bye. Love you.
See ya. Bye.
You've been listening to Two Parkies in a Pod, a Parkinson's podcast with Dave and Kuan. To get in touch, visit the website twoparkiesinapod.com or send your voice notes or emails to hello@twoparkiesinapod.com.